If you are nervous about going in for an infertility consult or just a workup with your OBGYN because you've been trying to get pregnant for a while and you're not pregnant yet, today we're going to go over all of the blood work to expect, all of the procedures, and how to make them more comfortable. So, if you're new, my name is Jess. I am a certified nurse midwife and nurse practitioner. I do basic infertility care, and I am also an infertility mama. I conceived my daughter Ingrid after 3 rounds of IUI or intrauterine insemination, and have, after 5 rounds of IUI to conceive my second child, have now moved on to IVF. So at a basic infertility workup, typically this can be done with an OBGYN or a nurse midwife or a nurse practitioner or physician's assistant. They're definitely going to want to do some blood work. The first and I think most important test is thyroid stimulating hormone. This is something that comes up a lot if someone has an irregular menstrual cycle, or they're just trying to get pregnant for a while and it's not happening. Fortunately, thyroid stimulating hormone, if it's off, is something that's usually pretty easy to fix. A lot of times we'll see women come in and their thyroid stimulating hormone is a little bit elevated, which actually means that your thyroid is working really hard to maintain the appropriate level of free thyroid hormone in your body. So if your thyroid stimulating hormone is elevated, it's actually a sign of hypothyroidism or low thyroid hormone, which sounds kind of counterintuitive. But most of the time that is correctable with a medication called levothyroxine or Synthroid. And I actually find that even if women come in for thyroid testing and it's normal, if they've hit the point in their infertility journey where they are seeing a reproductive endocrinologist and are doing either intrauterine insemination or IVF, most of the time reproductive endocrinology is going to start them on a tiny dose of thyroid hormone, whether they need it or not, or that synthetic thyroid hormone. And there's something we call subclinical hypothyroidism, where the normal range of thyroid stimulating hormone is anywhere from about 0.5 to 4.5. But really the ideal range for getting pregnant is between 1 to 2. And so when I went in for my basic infertility testing and I had my thyroid checked, my thyroid stimulating hormone was 3.5. And even though my amount of free thyroid hormone in my body was normal, my midwife at the time still started me on levothyroxine just to get my thyroid hormone into that normal range that's ideal for pregnancy. The next test you can expect is called Prolactin. That is another blood test. It's a hormone that's usually associated with breastfeeding. But sometimes a small tumor can grow in your pituitary gland, or it can be elevated for other reasons, and it can also make your menstrual cycle irregular. Elevated prolactin can be a cause of recurrent pregnancy loss. And so that's another hormone that typically we check. And then if it's persistently elevated in my office, I would refer that patient to endocrinology. And then I would say the third most commonly tested hormone for infertility is progesterone. And we specifically want to check progesterone on the 21st day of your menstrual cycle. Progesterone is going to tell us if you ovulated or not. So typically we have patients start counting on cycle day 1, so the first day of bleeding, and then once they hit day 21, come in for a blood progesterone level. And if that level is less than 3, we know that you did not ovulate. Now, this can be a little bit trickier to figure out in patients who don't have a typical 28-day cycle. So if I have a patient who comes in and they're like, yeah, sometimes my cycle is 28 days, sometimes it's closer to 35 or even 40 days, then what I'll have them do is still come in on that 21st day of their cycle to check their progesterone. And then a week later, if they have no signs of starting their period, I will have them repeat that level again. If the level is still less than 3, then I know even if they are going to ovulate later in their cycle, they're not really ovulating consistently. Other blood work that might be checked, in the medical community in Western medicine, we love to check a complete blood count. And I feel like it gets checked whether you need it or not. I'll see patients that come to me for a follow-up from the emergency room for, a broken toe or nausea and vomiting in pregnancy. And gosh darn it, they checked their complete blood count. And so that's one of those things that we do check a lot. Mostly for infertility, I would say we'd be ruling out anemia, but it's unlikely that that is like the main cause of your infertility. And certainly there are other reasons to check it too, but I find pretty much anytime blood work gets ordered, that gets added to the panel. And then I would say a more useful test that might be ordered is genetic screening, or genetic carrier screening rather. And that's something that your OBGYN or healthcare provider should go into pretty thorough detail on if that's information you want to know or not. The biggest panel of genetic screening we have tests for 274 different medical conditions that you could be a carrier for, that you could potentially pass on to your child, or that could potentially be a cause of recurrent pregnancy loss or infertility. Most of the time, they will just check the female partner first. And then if anything exciting comes up, check the male partner as well to see if they are both a carrier for something that they can pass on to their child. And the way we had actually done it when we first started our infertility journey was I had my husband get tested because he's Ashkenazi Jewish, and there are a few genetic conditions that are more common in that population. And so I just thought it would be interesting to know if he was a carrier for any of them. And then we also had me tested as well. And the only thing I tested positive for was a type of dwarfism. I believe it's called Ellis Van Creveld syndrome. That is more common in like Germanic populations. Fortunately, both of us would have had to have been a carrier for that to be causing problems or causing recurrent pregnancy loss, which fortunately my husband was not. I also find a lot of times we'll check vitamin D, just because where I'm working, we're in the Pacific Northwest, almost no one's getting enough vitamin D unless they're supplementing. And that is actually a cause of miscarriage, cause of infertility. So that's typically something we keep an eye on out here, but may not be a bigger deal in other parts of the country, or as big of a deal in other parts of the country. If it has been a while since you've had STD screening or a Pap smear, your healthcare provider is probably going to recommend updating those things as well. And I also find a lot of times they like to do screening for Rubella Immunity, which is blood work. Your Rubella status is not going to impact whether or not you've been getting pregnant. So I kind of think it's a silly thing to check, just because if you're not immune to rubella and you want to get the booster, that is going to delay when you're able to start trying to conceive again. So typically I don't check that in patients, because the last thing they want to hear is like, oh, hey, I think you need this booster. And then it's going to delay when we can start trying to get pregnant. Something that I forgot to mention in the video last week, so if I look different, it's because it's in next week and I'm filming a different video, is anti-mullerian hormone. This is something that is not always going to be checked at your first infertility visit. It's really going to depend on the type of procedures you're looking into and probably who your provider is. So definitely if you are at a reproductive endocrinologist's office, they are going to check your anti-mullerian hormone. An OBGYN or midwife or NP might not. And sometimes I do check it in my patients at their initial infertility workup, just depending on how old they are, how long they've been trying to get pregnant, what their exact scenario is. But anti-mullerian hormone is a hormone that checks your egg reserve. And I find it's most commonly used if you are considering IVF. They want to see your AMH, we call it, over 1. That's typically going to indicate that you're going to have the best ovarian stimulation response if they're trying to do an egg retrieval. Sometimes I will actually order it for patients who are in their like early to mid 30s. And they're like, well, I want kids eventually. I'm not partnered right now, or I'm not ready yet. And I just want to know, like, am I going to be able to get pregnant later? And honestly, like, we can never guarantee you that. You never know until you try. But sometimes I will just check that value, because we know if the AMH is really low, like, you probably don't have a lot of time to mess around and wait to start trying to conceive. And I do feel like that can be useful information. One thing that's really interesting about anti-mullerian hormone is you would think if it's checking your egg reserve or ovarian reserve that it would always be going down. It wouldn't be able to go up. But there are some scenarios when women have done things like changed lifestyles, changed diets, where their AMH has gone up. And I cannot even pretend to understand how that works. But if you have a low AMH, don't despair. There are things that you can do. As far as procedures go, you can definitely expect a pelvic ultrasound. This is done at various times in your cycle, depending on what the specific concerns are. A pelvic ultrasound is going to get a really good look at your ovaries. So it could tell us, do you have a lot of follicles on your ovaries? Do you have signs of polycystic ovarian syndrome? It could help confirm that diagnosis. It could also help find problems that might be inhibiting implantation of an embryo. And so that would be things like uterine fibroids, uterine polyps, calcifications in the uterine lining. But it's not the most definitive diagnostic test. So sometimes it can kind of guide further diagnostic testing, like a lot of times based off of findings on a pelvic ultrasound, then they may decide that they need to do a hysteroscopy, and I'll get to that in a minute. What you can expect with a pelvic ultrasound is you will need to show up with a full bladder. Most of the time, the ultrasound tech will do imaging through your abdomen, so with a wand over your stomach, and then they will have you empty your bladder and do a transvaginal probe. So it is a pretty invasive test. Most of the time, they can get you pretty comfortable, but if you have a history of sexual trauma or vaginismus or any type of condition that just makes it really difficult to tolerate penetration, that may be something you want to mentally prepare for. And it is definitely okay if you've got that history or you have a hard time with that, ask for medication. It's okay to ask for anxiety medication. I wouldn't say that the average person probably needs anxiety medication for a pelvic ultrasound, but if you think that's going to be a problem, it never hurts to ask. So based off of the findings of the pelvic ultrasound, if your provider recommends a hysteroscopy, that is definitely a more uncomfortable procedure that involves placing a camera through the cervix into the uterus to help visualize what's going on in the uterus. Is there a polyp that they need to remove? Typically, they can remove it during a hysteroscopy. And it's really going to vary from place to place whether they offer you anesthesia for that or not, which is really unfortunate because it is not a comfortable procedure. I've had 3 or 4 of them at this point, both with anesthesia and without. The first time I had one was with a OBGYN that was actually my boss at the time. I'd had a pelvic ultrasound with a large fibroid. They couldn't tell from the ultrasound if it was impinging on my uterine cavity and causing any problems with implantation. And so she said, well, why don't you come in for a pelvic or for a hysteroscopy? And fortunately, because she was my boss and we had this great relationship, she wanted to take really good care of me. So she told me to take ibuprofen beforehand. She told me she would give me Valium or diazepam to help relax me. And she gave me Vicodin as well. And after having that as the precedent for how to experience a hysteroscopy, I will not accept anything less from here on out. So I was super relaxed when I went in. I was really nervous about it because I typically don't tolerate speculum exams very well. And I knew that she would also have to place a tenaculum on my cervix, which is a pretty barbaric looking medical device that's a clamp that holds the cervix in place. So that way the uterus isn't moving around when they're trying to put the camera through the cervix. And I will definitely say Google that at your own risk. I thought about bringing a tenaculum and showing it, and it's actually you might not want to know what that looks like before that goes into your body. So I will leave that up to you. But I will say I've had a tenaculum placed on my cervix both with and without numbing spray. And oh my gosh, does the numbing spray make a difference? So it's called hurricane spray. It's just like a lidocaine spray. It's actually the same stuff they use to numb your gums at the dentist's office. And when I was in midwifery school, I had a gynecology provider tell me oh, it doesn't make a difference. You don't need to use that. She was wrong. It absolutely makes a difference. I got an IUD before I'd ever had a child and had to have a tenaculum, and my provider did not use that numbing spray, and I felt like I was going to die. I have a very high pain tolerance. I had a baby with no drugs, but that was the worst pain of my life. I thought I was going to vomit on my provider. It was so terrible. And then when I went in for the hysteroscopy, I was really nervous about it because I'd had that previous experience, but the numbing spray, the 800 milligrams of ibuprofen, 5 milligrams of Vicodin, and I think she gave me actually 10 milligrams of Valium, which was way too much. 5 milligrams would have been fine. But I had that all on board. And then I had my husband with me there to just hold my hand and help keep me calm and say the procedure was totally tolerable with that level of anesthesia. So I was, still awake for the procedure. So I guess it was not even anesthesia, just pain medication on board. The office I first went to for reproductive endocrinology did not offer me anything. They just offered me ibuprofen. And I said, nope, actually, I will take a Valium if you want to do another hysteroscopy. And they gave it to me. And fortunately, I had Vicodin left over from something. I don't even remember what now. So I took that as well. And I had my husband drive me. Like, definitely, if you're going to take those medications, you need to have a driver with you. And I asked them to use the numbing spray, and they did. And so my second hysteroscopy, also very tolerable. I thought that was fine. And then the third time I had to have a hysteroscopy was for retained placental tissue after the birth of my daughter. And because they knew they were going to be putting instruments in and removing stuff, fortunately, they put me to sleep in the operating room for that. In the office I actually work at now, it's just me and two OBGYNs, but the OBGYNs do the hysteroscopies or not in our office. They do it at the hospital in the operating room under anesthesia. And I don't know why we don't offer that more often. Well, I do know why. It's because we don't take women's pain seriously, but definitely it is okay. Ask for pain medication, ask for medication for anxiety. And if your provider is like, oh no, you don't need that, it is okay to find a different provider, especially with infertility care. You are paying out of pocket most of the time, like 99% of the time. They should be waiting on you hand and foot. They should absolutely be bending over backwards to take care of you and make sure you are comfortable. So if that's not a priority for them, that is probably not a place that you want to be receiving care. And then the final procedure that you can anticipate having at a basic infertility workup is called a Hysterosalpingogram, which is a $10 word for we put dye through your uterus and fallopian tubes under x-ray to make sure both of your fallopian tubes are open. And this is a procedure that's important, especially if you've got a known history of endometriosis, if you've had chlamydia, if you've had pelvic inflammatory disease, so they can evaluate, like, is there scar tissue or anything blocking your fallopian tubes? And is that why you're not getting pregnant, because the egg can't get through your fallopian tube? And also with an HSG, again, uncomfortable procedure. They are going to use a speculum. They are going to use a tenaculum. And it is okay to ask for all of the medications I previously mentioned for a hysteroscopy. Ask for anxiety medication, ask for pain medication. If they tell you, like, oh, just take 800 milligrams of ibuprofen, you'll be fine. Like, yeah, you probably will, but it is going to be way less comfortable than if you asked for the other medications. And then for your male partner, he gets to masturbate into a cup. Must be nice. Super unfair. The burden of infertility testing is mostly going to fall on the female. And it's so bizarre to me. I've had so many patients tell me, like, oh yeah, my guy doesn't want to go in. He, isn't willing to go in for a visit. And so I do this whole workup for my patients and everything comes back normal. And they've been trying to get pregnant for over a year. And it's like you're questioning their manhood. And I feel so fortunate that my husband is totally on board and totally supportive and has never had any problem going in for any testing. Because there are definitely some guys out there that are feeling kind of stubborn about it. So we love to quote the statistic in infertility that 30% of the time the female partner is infertile, 30% of the time the male partner is infertile, and 40% of the time both partners are infertile. So it is really important to have your male partner tested. There certainly are other procedures and testing that can be done if you are struggling with infertility, if it's been more than a year since you started trying to get pregnant and you're not pregnant yet, depending on if you've had miscarriages or not. This is what to expect at a basic infertility workup. Depending on the results of the tests from the blood work and these procedures, you may need additional testing. And definitely if you have had multiple miscarriages, there's a whole other set of blood work that you can anticipate having done. And I will do a video on that later. That definitely warrants its own video because it's a whole other beast to conquer. So if you found this video helpful and you want to learn more about infertility or follow me on my IVF journey, I am desperately waiting to get a date for a cyst check ultrasound so I can start taking meds for egg retrieval. I'm hoping any day now I can do that update video. I've been on birth control for 2 weeks and it's killing me. So stay tuned. If you found this helpful, hit the thumbs up, subscribe, and I will see you in the next video.